Hey y'all, happy baby Friday. Hope everybody's having a good week. Um, I am flying solo today, so you get just a little old me here for talking about audits today. So I'll be looking for a lot of audience participation and comments as we go through. And I put out, as we're going through different things, I already put up some links in the chat there for us. So some of the things I'm going to be showing today, because everybody always asks me, can you post that link again, or can I see that again? So I already put them in there for you. So all the links to things that I'll be showing today will be able to go ahead and are already in your feed to take a look at. So if y'all, as you come in, could just give me let me know that you're here, say hey. Sorry, I'm messing with my hair. So I can see who's on and, moving forward as we're discussing and be able to answer y'all's questions as we go through some stuff. First of all, before I get into the discussion that I have today, which is audits, something that I know is always on everybody's mind and that we are looking at all the time in the practices and very, very aware of, because they seem to be on a rise. So we want to keep definitely a handle on what's going on with those. But I wanted to first say, since this is coming up on Memorial Day weekend, that to anybody that has either served or has family that has served, thank you very much for your service to the country and for the sacrifices that you, your family, that those individuals that served have all made for the United States. So really, really appreciate it. Love our military and all the things that they do and have done for this country. So, okay, now on to, and I have some little tidbits about Memorial Day too, because sometimes it takes people a minute to get on. So I like to just chit chat a little bit at first. Did you know that Memorial Day, at the beginning of its inception, it came about in the Civil War, but it was originally called Decoration Day. That was the original name of Memorial Day. And that was because when the proclamation was made, they had said that it would be a good time to go to fallen soldiers' grave sites, and decorate, their tombstones and things like that for their service to the country. So it was called Decoration Day. But then it became a proclamation and a law, and they changed it to Memorial Day. And Memorial Day used to be celebrated on May 30th. So it had a hard date. That was the date we always celebrated it. But then they did this thing about an act where, because if you do it on May 30th, then one day it would be, one year it'd be Monday, the next year it'd be Tuesday, the next year it'd be Wednesday. So they wanted to make sure that there was a static day that Memorial Day was always celebrated. So now it's the last Monday in the month of May. So those are just some little Memorial Day trivia tidbits to kind of throw out there and wow your friends with, if you would like. So, and let me see who I got coming in here. I have, good. I got lots of people. I have Teresa Kelly, hey, from Arizona. Charmaine, hey, Charmaine, saying hey to everybody. And we have Kimberly Jolivette Williams, of course. Hey, Kimberly, how you doing out there in Texas? And some things come through as LinkedIn users, so I can't tell exactly who you are. So, hey, anyway. Bridget, hey, Bridget, good to have you on. And Tabitha, Peter, Guadalupe, lots of different people. Teresa Kelly. It asks if I'm talking. It says it can't hear me. Can y'all hear me? Oh, obviously you can't, because somebody said, thanks for sharing. I love history. Okay. So Teresa, maybe you have yourself muted, or you have your sound turned off on your laptop, I mean. So check that, please. But y'all give me a thumbs up, please, so I know that everybody else can be hearing me. Hi, lady. How you doing? I would appreciate that, just to make sure that I'm not here just sputtering off and nobody can hear me. Believe me, it wouldn't be the first time. So let me see. Okay, well, I'm not seeing thumbs up either, so I'm not sure. Oh, good. Interesting Memorial Day history. So yeah, y'all must be able to hear me. Okay. All right. So now let's go ahead and talk about audits. Very, very cool thing. It's always a good way to get an eyeball on what's going on in your practice, and do them internally before somebody does them externally, right? So we're going to kind of talk about both. First, I want to start at talking about audits done from an external standpoint. So if y'all are kind of just cruising along, doing your thing, and then you all of a sudden get hit with these audit requests that are coming in. Oh, great. Thank you, lady, for saying you hear me loud and clear. I appreciate that. So the first question sometimes to think about is, well, who's at risk for audits? Well, if you submit a claim, you're at risk for an audit. That's all it takes. So if you are submitting something to a payor to get paid for a service that you did, and if you have contracts signed with them, especially in all the payor contracts, it says, we reserve the right to, check on you anytime, because we're paying you for something that we need to be able to check and see and verify and validate that, you did what you said you did, and we're paying you correctly. So if you've ever submitted a claim before, you can be audited for it. So, why would you get chosen for an audit? Obviously, if you send one claim in, the chances of you getting pulled for an audit are pretty slim. But, depending on who you're looking at, if you're looking at the government versus looking at private payors, from the government standpoint, if, the big thing that everybody talks about is if you're an outlier. So what does being an outlier mean? An outlier means that, because and a little funny story in my head, I had a physician that I saw that he was an outlier for use of modifier 25, meaning that among his peers that are of the same specialty in the same geographic area, he's way above or way below what everybody else is kind of doing. So you're an outlier. You're kind of out of the box of where everybody else is on average. So I had said, well, you're an outlier, and we need to take a look at some of these things. And he would walk around, and he went out into the hallway where the nurses and things, where he would come after we talk, and he goes, "Ooh, I'm an outlier." And I was just like, yeah, no, that's not really a great thing to be. I wouldn't be out there spouting out that you're an outlier to everybody. And there may be reasons why you're an outlier. If there's a valid reason you're an outlier, then it is what it is. Sometimes you may be an outlier because of the type of patients you see. So you see more patients with a certain condition. Sometimes I found in different specialty areas that you will get a patient base that either, like, all of the really bad ones end up coming to me. The other physicians, when they don't know what it is, they send them to me. So I end up getting all this really bizarre stuff that I have to do all these things for. So, my patients, really are, more complex or at that higher level because they've already seen 2 or 3 other physicians before they get to me. Or there's one particular kind of condition that you treat, and so you get a lot of patients that seem to have the same condition. And so, there could be things like that that may cause you to be an outlier that, don't mean anything other than that just happens to be your patient base. And so if it's for reasons like that, the fact that you're an outlier is just a fact. So it's not anything that you should be overly concerned about, because if a payor were to ask for some records because you were an outlier, And as long as your documentation is where it needs to be, that's the key point, right? So as long as your documentation is where it needs to be, they'll see that, well, yeah, that's just his patient base or her patient base, and that'll be it. So there won't be anything there for them to dig into. So just a fact of being something doesn't really cause any harm. It's as long as your documentation practices in the practice are where they need to be. So those are all kind of little worry points that get in there. Nobody likes to hear that they're having records reviewed or being audited. So but it doesn't necessarily mean anything bad. Also, you might get it if you've looked at what is coming out from the CERT-Reports, the Comprehensive Error Rate Testing Program, or what the recovery audit contractors, the RACs, are looking at. So there's different things where you can look at if the government is focused on something and you happen to be in that specialty, or you happen to do a lot of that service, well, then you might get pulled just because of the fact that you're with a group or do something that for some reason the government's watching right now. From a commercial side of it, same kind of thing. They all have their software, their statistical data things that run, and it can sometimes be just a random thing where they literally are just kind of checking on things, and so they've pulled a few and they'll just ask you for a few records. So there are just multiple reasons why you may be being audited. So talking about things in here, then I wanted to show you a couple places where looking at things and showing you where you can find different, let me take this, let me move my LinkedIn down. Because I don't want to be looking at myself as I'm trying to show y'all something. So let me pull up my first one, which was the CERT-Reports. So you can look and see what the government's taking a look at, and what they're looking at from the CERT program, what they're looking at from the RACs. So I just wanted to show you a couple different places where you can go to look and see what they're taking a look at. And those are things that I've already loaded up into the comments section and LinkedIn for y'all. So they're already there for you to go take a look at. So, I mentioned the RACs. The RACs are the recovery audit contractors. And what they do is they are kind of the hitmen, so to speak, for the for CMS, because CMS, there was just so much auditing and so much to look at. CMS was like, we just can't do it all. So, they outsourced that stuff, some of it, to the recovery audit contractors. So with the RACs, they will take a look at different things, but they're only allowed to look at certain things that CMS has told them they can go look at. So they can't just randomly come and just ask you to just start sending them records for no reason. They just kind of want to see what you're doing. So I wanted to show you an example, because some people don't know that the RACs will post on their sites what they happen to be looking at in that particular, time frame when it was approved, what Medicare has said, they can go be taking a look at. So with the RACs, you have 5 regions for the RACs, I believe. And so depending on what region you are in will depend on which one you would get a notice from. And so, but the site I'm going to show y'all is from Performant, which is one of the, basically there's 2 RACs and they just kind of share different regions. There's Performant and there's Cotivity. So let me share my other screen here. All right, let me make this as big as I can. So this, and I'll take myself off so you can see it even bigger. So this is off of performance. And as you can see here, starting at the beginning, we have visits to patients in swing beds, incorrect coding, what the issue number is, the type of review. So this will tell you whether it's automated or whether it's complex or semi-automated. If it's an automated one, that means that the RAC will never ask you for records. You will just get a letter that says, we did an automatic review of your records on this issue and found that there's errors in your coding, and we want this money back. So you'll just kind of get a demand letter. You'll have no clue that it's even happened. And they usually, when they're doing those, it's ones that they don't need medical records for, because it'll be things like units of service where you should only be reporting one a day, but for some reason, somebody in the office is reporting multiple units of something. So there are things that are just outright errors that they don't really need to look at records for. And when they do the semi-automated, those are ones where they use data and potential human review of the record. So they kind of match them up where they spot check some things. And then when you see that they're complex reviews, that's when they're going to send you the request for medical records, and that they are going to do the medical record review of whatever it is. So those are when they're looking at levels, or looking at modifier 25s, they're looking at those kinds of things that they have to assess the medical record documentation in order to make a decision on whether or not it should have or should not have been paid. So you can see that here under the review type, and then what provider type this applies to. So this one, the first one there is professional services for physicians or NPPs, what region it's involved in. Remember, I said you can find your region if you go to the CMS website, and it'll tell you what state or states, when it was approved, and then it'll give you details, kind of like when you look at the OIG work plan. So if we click on this one just to see, it'll tell us that the description of it is, if inpatient care is being billed by the hospital as inpatient hospital care, the hospital care codes apply. If the inpatient care is being billed by the hospital as nursing facility care, then the nursing facility care codes apply. So it'll tell you why they're looking at something. So you can kind of go through and see, and you can sort them out, but you can filter it by the regions or by the state or by the provider type, because they'll have different ones. So you'll have ones here, as you see, for professional services. This one's for distal claviculectomy, incorrect coding. So you can kind of just go through here and look and see if there's things that the RACs are looking at that are things that you do. So maybe you need to take a check on those, or be keeping an eye on those services. Okay. So that's where you can go to look at for the RAC stuff. And now that's for that specific region. So if you're under Cotiviti, then you would have to go to their site and look at their stuff. So just make sure, you're looking at your RAC for your region. But I just wanted to show you an example, because I've heard from some people that they didn't know that this was a thing that they would actually tell you. So yes, there are more than one RAC. So Cotiviti and then this Performant, those are the two, and they've got different regions in the United States. All right, so also with the CERT program, you can go to where the CERT stuff is, and then place in their things and look at what their statistical data is showing from their reports. So that's where the comprehensive error rate testing program reports live. And with the CERT program, they're not really looking at your errors. What they're looking at is when and how it was paid, and if it was paid correctly by the MAC, or if the MAC should have been looking for, records or should have been denying those things. And so it kind of gives the RACs a little tip off to where there may be some documentation issues on the provider side. And then that's when you start seeing that they may feed over into the RACs to say, okay, why don't you guys go ahead and start looking at these things? So they kind of all play together and come together to, end up being where we're getting all these things. So let me pull that one up for you now so that we can look at that. So here you can see, and again, I'll make myself disappear for a minute so you can see this a little bit better. So here you can see, looking at this, where we have the CERT reports from 2021, 2020. So you can go by the year. So you can just look, of course, for the most recent one, the 2021. And they give us a nice big report here. That is the Medicare fee-for-service supplemental improper payment data. And let me tell you, if you want to get cross-eyed really fast, you want to go through some of this data. But you can see it's just full of appendices, and they all have projected improper payments, actual improper payments. They break it down by Part A and B. They break it down by region. They break it down by section. They break it down by type of service. So, I mean, you could go through this thing for just days and days looking for stuff, but it can give you some really good information about things that were found to be in error. So let's take a look at, the overall improper payment rate. If you look at this, they're saying that for 2021, there was a 93.74% accuracy rate of payment by the MACs on medical Part B claims. So that sounds pretty good, but the 6.26% improper payment rate led to $374 billion with a B of overpayments. And so they're asking what was proper, or sorry, that was what was properly paid. So the improper payment, even though it was only 6%, was $25 billion. So, they kind of want that money back. So they don't, they don't like losing that much money. And then it'll go and show you why they were improperly paid according to the CERT auditors. So you can see here, 64.1% was insufficient documentation. Well, there's a big tip off to you right there. So what is one of the number one things we want to look at in our office is our documentation, right? Because that is the king, that's what stands, right? That's the only thing we have to support what was done. And then you can see here, medical necessity, 13.6%. So that's where we have our ICD-10 and our CPT codes not matching, or doing things that, with the unspecified codes where they say it's not meeting medical necessity for those levels of service, things like that. And then we have 10% incorrect coding. So they choose the wrong codes. 6.9% of other. And then this one, I don't know how we get anything in here, y'all. Just shame on us. 4.8%, there was no documentation. So when the CERT sent them letter requesting records, they said, I got nothing. Or they ignored it. Which I do find that it's not that there is no documentation. It's that the office, somebody either threw the letter away, they didn't know what it was, or there was some kind of issue like that where it just never got looked at. But 4.8%, that's an automatic denial if you don't respond to these things. And that just makes us look really, really bad, that almost 5% of the time they're saying that, we got nothing. So, and then it breaks it down in here too, also by the categories, by the claim rates. And then it goes into all the crazy tables as you get down a little bit further. I'm not going to go through all 80 some pages of this. I just wanted y'all to see. So then they start breaking it down here. So you can go and hone in on whatever type of service it is that you're looking for. and things like that to get into what you want to look at for your practice or what might be affecting your practice. So those are a couple places where I think well, Jessica, I did put the links in the comments. They should have been the first thing that was in there. So I will, at the end, I have something to do, something special for everybody. So when I do that, as I'm doing that, I'll go ahead and I'll load all that stuff up in the comments again, for those of y'all that just can't see it or can't find it for some reason. Okay, so those are the first couple things. So you want to look at those things. Of course, if you've had anything looked at from a commercial payor and they're taking a look at things, you'll know that you're kind of on notice for whatever that issue may have been. Or if from the racks are where you will get those targeted probe and educate, the TPE. I'm sorry, the MAC, not the rack. The MAC is the Medicare Administrative Contractor. Sometimes I get tongue-tied and I can't remember what I said because it all rhymes too. So the Medicare Administrative Contractors have this targeted probe and educate program, TPE. I actually was helping a physician that was involved in one of those just recently. The targeted probe is they've noticed that there's something going on. And so they will request records, and they will request 20 to 40 records. So they're not going to be requesting, 8 million records for something. It's something that it's shown that you get a lot of denials in. So it's like, well, maybe we need to go look at this. And so the whole reason for the TPE program, according to the MAC, is to kind of give you some education, give you help in order to, overcome whatever issue you seem to be having, with getting your stuff submitted and getting your claims right. So with the TPE, they will ask you for 20 to 40 records, and then they'll audit them. And then if there's denials in those 20 to 40 records, then they will hold one-on-one educational session with you. And then they will wait 45 days, for you to put into play whatever, educational things they told you. And then they'll ask for another 20 to 40 records. If you do perfect, fine, you're all aces, then they won't review you for that issue again for at least a year. But if you still have errors, you'll go through another round of education. And they'll just do it again. Now, after the third round, if it's not showing from their perspective that you're compliant, they're going to turn you over to CMS at that point. And then when CMS gets a hold of this, because you've already been through 3 rounds of TPE, they may put you on 100% prepayment review, which is no fun. I've also dealt with some clients that have called me because that's what was happening to them. So every time, like modifier 25 is a big one where that happens sometimes. And so I had a client that called me. Every time she submitted a claim with a modifier 25, she had to submit documentation with it. They reviewed every single one of them, and they would not pay her if she didn't send the documentation in to go with it. So just imagine if you were under 100% prepayment review for something you did quite often, and you had to stay like that until you proved and satisfied CMS that you were back on track with whatever this issue is. Imagine the delay in the payment. So it could cause really big AR nightmares if that happens. They could also refer you to the RAC, to the recovery audit contractor, for them to just do a full-blown audit and start asking for takebacks and asking for money back from you. Or they could just extrapolate whatever the error rate is and say, okay, your error rate is still at 5% for this. So we're going to apply that 5% to your whole patient base of claims that you've submitted to us for this issue. And we're going to ask you for whatever that percentage, 5% of that is, that's what you're going to pay us back. So, the TPE program, if you find yourself in one, make sure that you are very much taking that to heart and listening to what they're telling you and following along with, the things that they're telling you are issues, and discuss with them if you don't believe, or understand why those things are issues. Make sure that you get the most out of those educational sessions, because they give you 3 cracks at it. And then after that, they kind of turn it over to CMS. And let me see, I got some comments coming in here. Oh, thanks, Terry. Terry's putting some of the stuff in there for me, the links in there. So yes, I'll get them all up in there again, but it looks like Terry's got quite a few of them in there for me already. All right. So some of the other things looking at and talking about audits then, as I said, so you've got all of this stuff coming in from the outside. You've got the government that can be looking at you, Medicaid, Lord help you. If you got Medicaid looking at your stuff, they're another one that, can be very, very aggressive in audits, at least in my experience from some of my clients that I've worked with. And then you've got your commercial payors, and commercial payors, they've got their own software. They've got their own issues that they're looking for. And, they may or may not have different rules from Medicare, right? So a lot of times with CMS, making the national decisions and the national guidelines, a lot of commercial payors, it's like, oh, well, okay, they already did it. Whatever Medicare says, that's good for us. I'll follow that. And so they just kind of follow along with what Medicare does. And, but they don't have to. And we all well know that sometimes what CMS says doesn't always agree with what CPT says. Like with some of the National Correct Coding Initiative, those NCCI, those bundling edits, sometimes what's bundled according to those is okay to bill in CPT. Another thing, a good example, E&M, with the prolonged services, with the new code for 2021 for the office visits versus what CMS likes in those prolonged services. That's why CMS, when they don't like something in CPT all the way in a code, they'll make those G codes, and they'll say, okay, well, we know CPT has a code, but, we don't agree with a little part of it. So we're making our own code. And if you want to get paid by us, you have to use this G code. So we already know that there's some times when they don't agree. So from a commercial payor standpoint, you can have the same thing. If they don't follow Medicare, they may follow their own, or they may follow some of Medicare, splatter in some of their own. So, they could be looking for a myriad of different things. So the best defense is a good offense, or the best offense is a good defense. I don't know which way, but, I think the best way to make sure, because anymore, a lot of times, and I've seen a couple articles that have been written this way too, where it says it's no longer if you get audited, but it's like when you get audited, because there's just so many different things, and there's so many agencies out there. It just seems like at some point, your number is going to come up. And if it's just a random pull, or if it's something that is just that they're looking at something nationwide, modifier 25, or who doesn't use modifier 25, right? At some point. So, who knows why, but that at some point, everybody's figuring now that somebody's going to ask me for something, to be looking at things. And yeah, Terry's making a great point here with telehealth. That's on the OIG list. Everybody's looking at that. It's very much payor driven, and when you sign a contract with a payor, you sign that you're going to do whatever that payor's rules are. And if you don't agree with those rules, then you need to go into negotiations and things. But, once you sign a contract, you're agreeing to that. And that's why one of the things where I get offices, and Terry, I'm sure you're probably seeing some of this too, with talking with your clients, when they hear from that payor, so they get a denial, they're fighting the denial. Maybe they got a stack of them for a certain issue. And I'll get a call and they're like, well, we've been fighting this and fighting this and fighting that. And I was like, okay, well, what kind of response are you getting when you're sending in these appeals? And if the answer is, that's our policy, that's one of our written policies that we're not paying for that, you've signed a contract with them, you're not going to win that. You can lobby to get them to change their policy, renegotiate contract to have that taken out of there. But if that's their policy and it's a written policy and they've got 8 million of them on their website now, right? And you're responsible for knowing all those policies because you've got a contract with them. There's really not much you can do with that. Terry also is commenting she's scheduled to an audit for 8 payors clear into 2024. So they definitely are looking at all this stuff. And with, on the LinkedIn posts, I put stuff in there. And for those of y'all that follow me on LinkedIn, you'll notice that I a lot post those fraud, waste, and abuse things where the OIG and the DOJ has done settlement agreements and has come in. I do that just so people are aware that, hey, these things are going on and they're looking at a bunch of different things. And some of it is just sad, blatant fraud, especially with telehealth, which is just enraging to me because I think telehealth could be a very, very important part of our healthcare system and helping people that are in areas that can't get to providers or their homebound patients. So, there's so many ways it can be so helpful, but because of the pandemic, now, okay, I'm going to tell you, this is my opinion. Because of the pandemic, we kind of turned it up a little bit faster and just kind of open the gates, to the barn, right? And just let the horses all scatter. And unfortunately, that has ended up with being you see a lot of these Department of Justice notices on telemedicine fraud for various different reasons. But it's highly being abused, and it's very sad because it's going to be very hard for us to kind of pull back in and try to get a handle on this stuff. And, and I can see where some payors may get to a point, like CMS did with the consults where they said, we're just not paying for them anymore. Y'all can't get this right. We've tried and tried. I'm not paying for it. So, we need to watch out and we need to be mindful of those things. So, but yeah, telemedicine, I think is a great thing, can be, but it needs to be used properly. And we need to have some really good legislation on how to use it. But that's my soapbox for telehealth. Okay. So, Terry also, yeah. Yep. It says Christine Hall. I love Christine Hall. She and Christine were just talking about that. If they say it's their policy, make them also give that to you or contact provider relations department, get a copy of contract. Yeah, Terry, that's a great point too. I go in a lot of offices when I go in to do audits or to meet with them about doing audits. And not only do I ask them about the actual records, because sometimes I do them electronically. Sometimes I'll dial into their system and do things. Sometimes they'll still send me paper records. But anytime I'm doing an audit, I will always ask where their contracts are and where their policies and procedures are for evaluation management, copy of their compliance plan. There are so many practices that I go into, they have no clue where their contracts are. They haven't seen contract. I just had a derm client. We were talking about because she had an issue with the payor and they were going through an audit from the payor. So I was helping them defend it. And as we're looking through things, I had asked, I said, well, let me see the contract with this payor. And she was like, well, the administrator said, well, we don't have any of those. And I said, well, when was the last time the contract was looked at? When does it rate? She was like, well, she's like, I signed it like 10 years ago and had never seen it and had never looked at it since then. So those are things that you really want to make sure you're taking a look at. Especially if you start getting those denials and they're saying it's in our policy or it's our policy, or, make sure you're taking a look at that stuff. Look through your contracts, make sure you've got a copy of them. Have a copy of your compliance plan ready, have a copy of your policies on E&M and other things ready, that if a payor asks you for records, you want to send the records, but you also want to send your policies on coding back with it. So that they can kind of see your mindset and where you sit with those different kinds of things. So, there's just different little things like that when you're going through an audit that you can kind of, assist along and help along. So I did put in some tips here. So let me pull up a couple of those. Oh, and one other thing when we were talking about data, the Part B utilization data. Let me find where I have that. Okay, I want to show you one more thing. So I'm going to share my screen one more time. I'll make this bigger. So Medicare will put out the, the Part B national data, their utilization data. They put it out every year so you can kind of see it. This is definitely something when you're doing internal audits, or you're planning on doing an audit, just taking a look at your records, where you can look and see the bell curve. When everybody talks about the bell curve, they break this down by specialty and then by E&M level. So here you see a level 1 for general practice. These are the services allowed, the allowed charges, the payment amount. So you can kind of see and compare between specialties if you look at the bell curve data. So this is all the data on the E&M codes. So this is another link that I'll put up in the comments for y'all. So just kind of wanted to show you that you can be able to break down your practice and stuff by their specialty to take a look at what their bell curves are compared to the national data. And they have it out here. Let me see if I can go back one more. So here on the site for Medicare, it's under the Medicare utilization for Part B. And you can see that you can go back a number of years to look at things if you want. They have the evaluation and management, then they have the lab procedures ranked by charges. So then the top level CPT codes ranked by charges. So again, just a wealth of data that you can take a look at and use when you're performing audits or trying to figure out what you should pick to audit, or see if there's something that that you should be looking at. So those are just all little things that you can use, all of those sites that I put up in here. So what are some of the tips? First one, if you get a letter from Iraq or the MAC for this targeted probe and educate, or from a commercial, but whoever, if somebody's sending you a letter asking you for records, don't miss those deadlines. With CMS and with the other pay, unless you've asked for an extension, once that deadline is set, those are hard deadlines. They don't care what you have going on in your office, especially if you don't communicate with them. So if you just ignore the letter and then it's the day before and all of a sudden you're like, oh, well, I guess we should start getting this together. If you don't get it to them on the deadline, you're 100% wrong. It's just automatic denial if you do not respond to the deadlines. So make sure you've got it up on calendars, you've got it flashing up on your laptop every time you sign in. Pay attention to those dates. I usually, when I'm working and we've got these deadlines, I always fake the deadline on my calendars and with my clients to be a week ahead of what the actual date is. So that way, if there is some kind of major catastrophe, I know that I still have a day or two in my pocket that I can, make sure I get this stuff to them. So, but don't miss a deadline. Make sure you're talking to the payor. If you think you need an extension, you can request one for extenuating circumstances and tell them why you can't do something. Then you also want to look at the records that they've requested prior to sending them out to the payor. If you get a records request and they want to see 40, 50, and sometimes people will say, well, they just, and I have offices that tell me this. Well, yeah, sometimes the payors, they'll send a thing over and they ask for a couple records. Yeah, I just send them to them. And, they don't think much of, they're not requesting records from you for absolutely nothing. There's a reason why they're asking you for a record. You'll want to look at the record and make sure it's right before you send it over, or look at what you think they may be looking at, or make sure it's complete. I've also seen where I had one client that did poorly on an audit because the person that was responsible for copying the medical records and sending them was not sending the entire thing that had to do with those dates of service. So it looked like they were missing consents and they were missing certain things that needed to go with those dates of service with the encounters. And so they were denied for some of that stuff that actually was in the chart. They just didn't send it along. So make sure that when you are sending it, that you're sending the complete record for that encounter. If they are referring to another date in a note, and they're saying, because I know for the office visits now, we have that laxity where we're not dependent on history and exam any longer. But for other E&M services, until, they come out with the new guidelines for everything else, you still may be using some other portions of data. So if you're pointing over to something else in the medical record and that's being used to support the service you're doing, you need to send that along with the medical record when you're sending it to support the service that you build. Now, and lady, definitely that's where I was going with my next one. But send only what is requested. So lady made a good point too. She beat me to it. She said, don't send more than what they request. And sometimes when people get nervous or but when people overtalk, sometimes when they're nervous or they have that, so sometimes the tendency, they just, they ask for, we just send them everything. We just don't open the door any more than you have to. So if they're asking for a specific date, just send that date, because not only that, you could have issues with if there's, like notes from other areas or HIPAA issues that you're sending more than is necessary. So just make sure you're only sending out what they're requesting of you. Don't add to it. And Sarah's making a good point too. I think that's a great idea, Sarah, to set up a team to specifically handle audits. That's always a good thing to try to do. And a lot of practices, they do have designated people that work on specific parts of things when there is audit requests that come in. And then, seek outside help when needed. If the request is too big, or you're looking at it and you think that there's a little murkiness in there, or you could be having some issues with it, if your internal staff is strong as far as the coding and documentation area is, maybe you need to contact a healthcare attorney to kind of help with if you think you're going to have to negotiate payback and different things like that. Or if you are looking at the records and don't know if what you're doing was right, or if you should be paying it back, and you don't have office staff that have that level for expertise, then maybe you need to get a consulting company that will audit the records and tell you, and I've done that before in fact, this one client I was just talking about, that's what I did. I audited the records that they audited, that the payor audited, and saw where I agreed or disagreed with what their findings were. And, then we took that back for negotiation with the payor to say, well, we had an outside consultant look at these things, and according to their audit, it's this percent, and then you start to have discussion. So that's something too you may want to consider, especially if you're looking at large dollar amounts for paybacks, or things you just don't think are right, but don't think that you have, the necessary bandwidth in your practice to be able to move forward with the stuff yourself. So those are some of the things that I would, suggest, and my little tips there for going through things. So looking at your stuff internally, what can I do to make sure or see where we're going or what's happening? So what you want to do, as I was saying and showed you before, look at your bell curve, compare it to your other practices, compare it to the national data, and take a look and see where you kind of fall. Is everybody else, one of the things that was interesting in the E&M study that they were doing, that they're finding that there seems to be more, more level 4s now that we've moved to this new way of doing the 2021, office visit E&M services. They're seeing a higher shift on 4s. So, does that pattern hold in your practice? And if it does, is your documentation supporting those 4s now? You want to make sure that what you're doing is in that safe area, and your documentation is where it needs to be. You also want to be up to date on, all the coding guidelines. We know from CPT, the book, right, changes once a year, but then they do have the quarterly updates as they'll put on the site when they have the errata, or they'll have like the new vaccination codes and things like that come out more often. But they're not going to reprint the CPT book every time they do something like that, because good Lord, we'd be buying them every time you turned around. So make sure that you go to the AMA site and are looking at, what the quarterly, what the changes are, what the errata they may be putting out, keep a track on that to make sure you're up on it. And then also up to date on what the payor policies are. We know Medicare changes its mind on different things, and so they're coming out with different guidelines. And then whatever the LCD and NCD, so you have your national coverage determinations, and which is Medicare federally, saying this is, what we say nationwide, and then the Medicare administrative contractors, the MACs, can make local coverage determinations, LCDs, that are for our region. These are things that are important to us, so we're going to have these guidelines. Commercial payors, again, they can come out with stuff all the time. It's hard to keep up with all of this stuff and to know what's going on where. So, just on the payors that are the big ones for your practice and the ones that affect, your practice the most, keep an eye on them. You can sign up for some of them to be alerted when they make changes or when they do things, so that, you may get notified that there was an issue, there was a guideline change, or there was a subject change. I get some of the things on, for Medicare, we always get the things that there's this new thing up and there's this new posting. And those are some of the things that I try to put on and put out to LinkedIn when I see them, if I think they're, broad-based in what they might be doing. Same with your diagnosis coding. I just posted a thing before I came to do this, that the ICD-10 PCS for 2023, they just put those up and posted them. So I put a link to that on, I put a thing up, did a post on LinkedIn about, I don't know, an hour ago with those. So, make sure that you're looking at what's coming so that you can be prepared. It's always a good idea. So just try to stay up and look and listen to Terry Fletcher. She's got her podcast, and Christine Hall, and Brian Quee, those of us that have different things out there, just try to be paying attention for what's going on and keeping up to date as much as you can. And then those self audits, like I said, make sure you're doing your self audits, either internally, if you have the staff and the time and the people. Sometimes you may have staff that is capable of doing them. It's just you don't have time to do it because you're working with skeleton crews. And now patients are coming back into the offices and we're seeing patients. You may still have some staff that aren't back in the office yet. You may have some staff that left, and there's just a lot that has to be done, and you don't have the people at the moment to do it. For whatever reason, if you need to, go to an outside agency. It doesn't have to cost you an arm and a leg. And it doesn't have to be 100 records to be looked at. You can have a baseline done to where you're making sure that at least you got some kind of an idea of what's going on. And then, from there, if there needs to be some education done, you can see what points that the physicians and other providers may need some help with, things like that. So, but I think that's a great place to start. And then, look at different things when you're doing the audits about what do you want to look at? Do we want to do a targeted one? So we're going to look at level 4s and level 5s because we're kind of nervous about those. Or do we want general one where we're just kind of looking at everything because we haven't had one for a while, so we want to see and see if we're just generally doing okay. Do we want to do it retrospective or prospective? There's all these other things then that when you're doing this that start to come into play that you need to figure out of how you're going to do it. Oh, Lady Medico, she says, oh my gosh, you said 2023. We're at half a year. I can't believe it. Yeah. I mean, it's you got to take a look at that kind of stuff. That it doesn't take long, right? We're almost into June, so we're about halfway there, right? Halfway through the year. So we're going to start seeing all that other stuff. And then, if you're looking at the auditing thing, as we're closing out on our time here, I'm seeing that we're just about up. That I have coming up. I want to tell everybody the next healthcare happenings. I'm really, really jazzed about this. We're going to have an extra special one. It'll be on a Friday because of everybody else's schedules. So it'll be a Friday, June 10th at 7 p.m. Eastern time. So you adjust your, when you see that, you'll get to adjust your clocks. But I'm going to have Christine Hall, Sonal Patel, Brian Quee, and Vanessa Moldovan. And we're going to do our networking thing. When Vanessa was on last time, when we were talking about modifiers, it just, the whole networking thing like ticked off in my head. And I said, a networking thing would be really fun. And she was just like, oh, I'm there, so I was like, all right. So when I got done with it, I started kind of putting a few feelers out to see, there's so many people that I could tap for this, but I didn't want the panel to be so big that, we were like all talking over top of each other and not getting any information out. So I went with these guys, Jennifer McNamara, who I had on last time for the healthcare happening. She was going to do it, but she had a conflict in her schedule. So we're going with these heavy hitters here, and we're going to do a networking session. So I think it's going to be really, really fun and really good. So somebody said, that's awesome. I thank you for thinking it's awesome, and said, do we need to pre-register? No, it's just going to be on one of my regular LinkedIn live broadcasts. So I'm going to, the week before, you'll get the notices up, with the invite saying, that we're having it, and you just click on like you normally do. So, yes, lady, it's through LinkedIn. So I hope y'all can make that one. And look, I'm very excited to have it. Also, I am, this weekend starts my first one doing a webinars live. I'm doing 3 live webinars on what I use as resource tools when I do audits. So I am calling it the Physician Auditors Toolbox. But it's not just for physician auditors. It's for anybody in the practice that, either audits part-time or is a coder or biller that also looks at medical records and is trying to help the physicians with getting, their audits on track and making sure that they're staying compliant with their things. So the 3 live ones I do, you can see on the screen there. It's going to be Saturday, May 28th at 1 p.m., Tuesday, the 31st at 8 p.m., and then Wednesday at 1 p.m. I try to do varying times and days to see what helps people more, because some people say I like weekends, some people say I like nights. So I did one of each. But if you go to the website and sign up to one of the live sessions, the cost of the webinar is $49. It's 1 CEU. But if you come to the live session, I'll also give you access to an additional CEU. It's a bonus CEU at no charge. And then also 20% off our auditing tools. And then I'll give away a free set of auditing tools to somebody. And then you'll be able to go and access the recording after that, for as long as you would like, as long as the information is still valid. I will have it up. So you can go to our website, chcs.consulting, and then go under the e-learning tab. We have a whole section for e-learning now, and you can sign up for whichever date, works for you. Now, the other thing I want somebody, let's see, is Terry Fletcher, are you still on? I know I'm at my time here, so I don't know if Terry had to jump off or not. But Terry, if you're on, could you just type real quick in the chat that you're there? Lady, I agree. I would love to have Terry on, but usually her schedule conflicts with when I do them. But yeah, I'm going to try to get her. But because yes, I agree. All right. So I think Terry must have had to jump off. Kimberly Jolivet Williams, are you there? Could you say, yes, I'm here if you're there? I just wanted this to be random. What I'm going to do, because what I'm going to do is I'm going to give somebody access to the webinars, the live webinars for free. I'm going to give away a free webinar registration. So I just want somebody to, oh, you're welcome, lady. Well, lady, since you're still, oh, yeah, there, good. Kimberly. Okay, Kimberly, give me a number, just a random number from 1 through at least, it looks like 20. So a number from 1 to 20. 17. Okay. So I'm going to go up here. I'm going to count 17 down in the comments, and whoever made the 17th comment is going to get the free webinar. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. So that is Tabitha and boy, Sove. I'm sorry if I, butcher your last name. So she is the winner for the free webinar. So Tabitha, I just need you to email me. And I will give you the code, the discount code, so that you can go on and register for, whichever day that you want to attend for the live session. Hi, Misty. I'm glad that this is the first time you're joining. I hope you like this, that you found this useful and got some good information. And if Misty, if you had to log off, I will DM you or IM you or whatever they call that, and send you a message that you won a free attendance. And then now I am going to just add 10 to that, and I'm going to do one more. So let's see, where's Misty? We got started out in a place that was good. I just am feeling nice here today. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 1, 2, 3, 4, 5, 6, 7, 8, 9. Lady, that would be you. So, lady, if you would just send me a message, I will give you the code that you will need to go ahead and get your free registration. So congratulations to those ladies. And so here is my email. It's just Betty Hovey at chcs.consulting. So just drop me an email and I will send you a message through LinkedIn too, so that you can attend whichever one you like. And if this is not one that you care for, we're going to have some more coming up. So you can save it and use it at another time if you would like. But thank you, everybody. I appreciate your time today. And I know the end kind of got a little fuzzy here and dragged, but I was trying to get this. I couldn't figure out a better way of trying to give this away that people didn't think that I was, just choosing people that I liked or making it up. So I wanted to be honest. So thanks for joining me today. And don't forget, be watching for the notice for the June 10th one for the networking. It's going to be really, really super cool. And please, if you have the desire to attend the webinar that I've got coming up, just go ahead and check us out. To our e-learning site is just elearning.chcs.consulting. And if you want to get notices about our upcoming healthcare happenings, our broadcasts and things like that, follow me on LinkedIn. Here's my information for my LinkedIn. And so I will throw up all the other things out in the chat for y'all. And thank you for joining me. And I hope y'all have a great Memorial Day weekend. Again, thank you to all who have served us and who have family members that have served us. Deeply, deeply appreciated. Thanks, y'all. See you next time.